Theme Session Assignment, Insulin and Antidiabetic Agent. Case 10, by PBL Group 10. Meet Mrs. K, a 58-year-old woman with type 2 diabetes for 10 years. She's been admitted for pyelonephritis and is receiving IV antibiotics. She was able to eat like usual. Despite treatment, she has persistent fever and leukocytosis. Her blood glucose levels during admission range remains high, between 10 to 15 millimole per liter. This raises an important question. What would be the choice of antidiabetic for her glycemic control during her admission? How should her glycemic status be managed in this acute setting? A basal bolus insulin regimen is the preferred approach. This regimen consists of: Number 1. Basal insulin, long-acting, to provide continuous glucose regulation. Number 2. Bolus insulin, rapid-acting, administered before meals to control postprandial hyperglycemia.
Why is insulin therapy preferred over oral hypoglycemic agents? Acute illness induces a physiological stress response, leading to increased secretion of counter-regulatory hormones such as cortisol, catecholamines, and glucagon. Hence, insulin is given to counter the abnormal surge of glucose from the stressors. Additionally, oral anti-hyperglycemic agents, particularly metformin, are contraindicated in acutely ill patients due to the risk of lactic acidosis, a dangerous condition that can occur in acutely ill individuals. What are the glycemic goals for her in this setting? Number 1. Target blood glucose, 5.6 to 10.0 millimole per liter, or basically 100 to 180 milligram per deciliter. This range is associated with improved immune function and better clinical outcomes. Also, avoid blood glucose more than 10.0 millimole per liter or 180 milligram per deciliter, as it can impair immune function and worsen infection. Number 2. Avoid hypoglycemia, which is less than 3.9 millimole per liter, as hypoglycemia is linked to increased morbidity and adverse infection outcome. Number 3. If persistent hyperglycemia, which is more than 10 to 12 millimole per liter, occurs despite basal insulin, intensification of therapy or IV insulin infusion should be considered.
What are the effects of poor glycemic control on the outcome of the acute illness of this patient? Uncontrolled hyperglycemia has significant pathophysiological consequences, including impaired immune function, leading to reduced leukocyte efficacy and increased susceptibility to infections. Enhanced bacterial proliferation, facilitating complications such as renal abscess formation and progression to sepsis. Delayed wound healing, increasing the risk of post-infectious complications and prolonged recovery. And lastly, increased risk of acute kidney injury, aka emphysematous pyelonephritis and multi-organ dysfunction, particularly in patients with severe infections.
Thank you for watching.